We've known for a while that the current fee-for-service models that most occupational therapy professionals operate under are bad for patients and bad for healthcare. Why? Because this model incentivizes volume of services over quality of services. If you are like me, you may feel like you've been waiting for years for value-based care to really take hold in the United States. But this new future has just felt like a distant reality. Our guest today, Dana Strauss, is a PT who sees things from a different vantage point. As she'll share in this episode, the future is actually here. It is just not evenly distributed. Value-based care programs have been piloted, and they are on the cusp of rapid expansion here in the United States. In our episode today, Dana will walk us through the value-based models that are currently out there, what ones are coming, and what you can do as an OT professional to prepare for this much-needed new reality. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this big topic of OT and value-based care, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this episode on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. If you are a regular listener to this podcast, you know that we usually kick off our episodes with a review of a new journal article. But since this is just a big sweeping topic, we are going to skip that part of our podcast and just jump into our discussion with Dana. Dana Strauss, DPT, is the Senior Director of Public Policy and Government Affairs at CVS Health, where she serves as an expert in Medicare and value-based care. Dana took her clinical experience as a doctor of physical therapy and expertise in the healthcare continuum and transitioned her career to value-based care and policy analysis and expertise. She believes the healthcare system can meet everyone's needs better. Her passion is moving towards the optimal patient experience and outcomes wherever an individual is in the spectrum of wellness, illness, or injury, chronic care, or a serious illness. She is optimistic about payer-provider synergistic relationships, making healthcare better for everyone along the care continuum, and is confident that innovative reimagining of the roles and responsibilities of sites of care, including the home, can lead to higher value and superior quality for all. So without further ado, I will patch Dana into this podcast. Welcome to the podcast, Dana. It's great to have you.
Thanks for having me, Sarah.
I am so thankful that you are here. I feel like you are someone I've literally been looking for years, someone who can talk to us about this transition to value-based care more fully. We have been stuck in this fee-for-service model here in the United States. I think we'll look back on it almost as like a comical fit for OT. We have never fit in this model. Like, we love intense collaboration, shared decision-making, really pursuing best practices. We love to tell patients, we're trying to work ourselves out of a job. And none of this fits in our current models. So, I cannot wait to hear about where healthcare is going, how OT can finally feel a fit. But before we get to those details, I'm so curious about your story and how you arrived at your current role at CVS.
Well, again, thanks for having me. I'm excited to speak to all of your listeners. And, once we started talking, I realized that OTs had, just as much opportunity in value-based care as PTs do. Of course, coming from this as a PT, as my profession, I've worked with OTs from the start, from my first job in inpatient rehab on a team with OTs and PTs. So I definitely have a really strong understanding of the value of OT and where it fits in, just like physical therapy. So I'm thrilled that this is of interest to your listeners. So I give you a little bit of my background. So Once I started as a therapist, and I've been around a long time, since 1998, about 6 months in, I just looked around me, and I had a wonderful job in a wonderful inpatient rehab facility, great colleagues, but I looked around and said, but we're not, but we have to fix the way this works. It just doesn't, a lot of this just isn't making sense to me. And that was my kind of first foray, many 25 years ago, into I was always looking for how we can make this make more sense, and how we can at least take what the incentives look like now and try to work with them, and even just having an understanding of what the incentives are so that we can work with them, which I think a lot of healthcare professionals really don't give much time or thought to incentives. So I ended up here because I had, in my pursuit of this, I found colleagues I worked with in a home health agency that I was with for quite a while. I found partners there and some in leadership that really wanted to develop a population health department and start participating in some of the earliest value-based care models. So this is right, Affordable Care Act created the Medicare Shared Savings Program and the CMS Innovation Center. So these are what really started and propelled the work of value-based care forward, was the creation of the Affordable Care Act. And we knew as an organization, we were really well positioned to do well in these models and wanted to do something to transform care. So built that up, an unbelievably incredible experience that I've taken what I've learned in those 4 or 5 years in building that with leadership and hiring a team and making huge change in how, seriously ill and chronic and acute patients are handled and the care that they got, and then moved into the private sector. I inadvertently became an expert in value-based care policy, because without doing that, and I did it on my own for the most part, without doing that, I could not create programs that would be successful. I had to understand them deeply. So I did a lot of reading. I did a lot of participation in webinars. I did a lot of talking to others who were successful in it. And I was like a lot of therapists who move into, a non-clinical role. I was in client success. In a startup, though, that also meant I was the, strategy director, or I was a VP, a strategy VP. I was in charge of policy and of finding opportunities in new value-based care programs. I helped build a pop health EMR with the team. So I had, again, this wide range of experiences because I took that risk of going to a startup. I came over to the company that I'm in now, which was purchased by a Fortune 10 company not too long ago. I came here in client success also. But, this is how serendipity works. I had developed all of this expertise, and it turns out when I came to this company, they didn't have value-based care experts, and they had a government affairs team. I didn't even know what that was. And that team had a need for a policy expert in value-based care because of the direction the company was going. And they asked me if I would be interested in interviewing for the position that was opening up. And I went through the process and got the job. And that's how I landed in this role in value-based care policy. And as this company's grown, and as it was purchased by a Fortune 10 healthcare company, the opportunities have grown and grown for me to have an impact on how healthcare is delivered, being able to participate at a high level in important coalitions and trade associations. I've always have the lens of a clinician looking at how potential policies are going to impact how care is delivered and how the incentives will shift. And that lens has been extremely valuable to me, to our organization. And I, not to speak for everyone I work with in coalitions, but I think that it's perceived as a real value and just an unusual kind of fit. I think I'm the only therapist that I've ever met that works in the health policy space. Not that anybody couldn't. It's like it's totally achievable for others who are interested. So, and that's how I ended up becoming an expert in value-based care.
That's so amazing. And I've been trying to listen to all the podcasts that you've been on previously. And I just keep hearing you talking. I'm like, you're so good at being like Does this make sense? And how do I find a team to collaborate with to figure it out? And I'm just like, I see you as uniquely driven in those two things. Where does that come from for you? Like, were you on a math team growing up, or what's that drive for you?
Oh, I think it's a personality trait. I have to know how things work if I'm going to excel. And I've just kind of always been on that path to, I have to do this to the best of my ability and, at the highest level possible. And
Usually
when,
those people aren't great collaborators, though. I
no,
have to
you're
know
right.
people. You do both.
Oh, yeah. I learned early on that it's critical to find not just leaders that believe in you and that can see the vision that you see, but to find others, maybe in middle level management and sometimes just peers that can get on board with a concept or an idea and fight against the typical system that we're just all so accustomed to. So maybe I give you just an early example of where I just saw a problem that I couldn't not bring it to my boss when I was first starting, but not just because it was a problem, but because I aligned that problem with an opportunity for the organization I was working with to try to create that incentive to develop this new program. So having been in inpatient rehab, I'm sure lots of your listeners can relate to this. There used to be a time when total joint replacements they all went to inpatient rehab. Not all, but the vast majority, and some went to skilled nursing. And I would see these patients and they would do fantastically well. In fact, within a few days, many of them would be walking around with canes. And I would have these, complex CVAs and traumatic brain injury and amputations and trauma patients that needed so much. You know how it, right? As OTs, we know how it is. So much hands-on care, couple of therapists, an aide, and then walking around the department are these total joint replacements that needed some hands-on care, but lots that they could do on their own. And I started to research, well, what is Medicare spending on this? Because it seems like it could be money that could be directed in different places. And it turns out at that time, 2001, it was something like $17,000 for about 10 days of therapy. And what I realized coming to home health, and I was doing a little bit on the side when I was working in inpatient rehab, what I realized was these patients, there was no medically necessary reason or clinical outcomes reason for them to go to inpatient rehab. There was no reason they couldn't come to home health. And not only that, this was going to be a driver of revenue for the home health agency and be good for patients, right? They got to come home. They were offered, if we could get the orthos to agree to this, they could be in their home environment. They'd have less risk of infections. It helps with mental health. It helps with the family unit. It helps with, just early mobility and all the things we know are great about care at home. And it took a while to get it off the ground, mainly because you're having to align the incentives of the physician groups, which, right, going a planned discharge home is a lot more work for them to have those conversations early on and not just discharge to an inpatient site of care. And so it took first some payers who only wanted to send patients home. It took the Hospital for Special Surgery in New York was sending us patients in New Jersey was sending us patients that they wanted home health for because they wanted to avoid inpatient rehab. And so as we are building this and seeing very high patient satisfaction rates, right, we'd see them somewhere between 7 and 10 times total before discharging them to outpatient rehab. And it was a better for patients, great revenue driver, and just made more sense. And that early experience imprinted on me. We can change things if we can figure out what the incentives are.
That's an amazing story to me. I'm so fascinated by you and I guess just your tenacity. So many of us as therapists, we see these problems, but we see the systems as too big, too immovable, too above our pay grade. And maybe even assume that someone somewhere has something figured out that we're not privy to.
Yeah. And that's so not true.
That's not
No,
and that's
I
not
mean
the case.
everywhere I've worked, it's not the case. I worked at that organization, some of my most favorite coworkers, my mentor for life, who helped move me through into different jobs and into pop health. Incredible organization. But people don't think they can fight the way things are, even if it's right and even if it's possible. And yes, your earlier point about you can't just be someone who has a vision and is willing to put in the work. You have to be a collaborator, someone who realizes these things do not get done because one person thinks it's a great idea, right? Building a coalition around an idea is just talking to people, right? It's getting passionate about things. And you want to laugh. For years and years, every job I've had, on my annual review, the two top things that they would always say about me, passionate and enthusiastic, Because it's just more my personality. It gets me excited and up in the morning. I wanted to have a bigger impact in something like that, where I'm changing the trajectory of care for a big volume of patients 10 years before the total joint replacement model came out. That to me was monumental. And it was just put that taste in my mouth for we can do better. We have to do better. And we're going to figure out how to do this.
I keep telling OTs, like, we have been in the era of the specialist, which just hasn't been the right fit for OTs, but we're headed into the era of the collaborator, and that is our fit. Like, just hold on, it's coming.
Yep.
Looking back at this fee-for-service model that we've been stuck in, we know it's bad, but I just want to rag on it a little bit more with you, like, because you're so good at telling us what's wrong with it. Can we just drive that home, and can I hear from you what's been wrong with where we are? So many things, but let's just relish in saying them out loud.
Oh, I'd be happy to. I mean, at its most basic, right? Fee for service is an incentive problem. And take that first for as it is, listeners. I'm not saying what's not coming out of my mouth is we need a single payer model, or we need everyone to be in a certain insurance program. I'm not saying any of that. The system we have in place creates no incentive for providing the right care at the right time. No one is watching most of what providers do. And when they do, such as things like prior auth or utilization management, when organizations like third-party payers try to find ways to put guardrails, everyone loses their mind. Not saying that that's all but perfect in any way, shape, or form. That needs reform too. But we're in this position because we are, the collective we, PTs, OTs, physicians, and everyone else who's paid by third parties, we are paid to do more and more and more of the things that reimburse the most. That has nothing to do with what's best for patients. They are completely separate things. Yes, the majority of the time, we are doing what we believe is the best thing for the patient, unless sometimes we are told by our supervisors that we need to do X number of minutes, or we need to do X number of visits, or we need to do X. I have heard it all from every provider type. Or we need to do an intervention rather than physical therapy or occupational therapy, right? Or we need to have imaging because it's easier than explaining that, no, you don't need it because it's not clinically indicated. We can go on and on and on. I'll make a parallel. I love analogies because sometimes we get stuck in our own square box. And if you make an analogy, you can kind of see it from that perspective. I don't know. I was writing my little newsletter and I thought about this. Say you think of us as, right, we are specialty providers. I'm not saying specialist. We're specialty type of providers who do a service and have an expertise that the public doesn't. And if we think about another type of like skilled provider outside of medicine, something like an auto mechanic or a plumber, right? We go to them, we don't know what's wrong, right? Or they come to our home, we have no idea. We're going to hope and trust and pray, whatever, that what they tell us is accurate and that what they recommend is best for us. But we have no protection unless we get multiple estimates and we bring in friends that know it. We have no protection against being billed for things that we don't need or that aren't the best, because that's not going to lead to their greatest reimbursement. And we all have stories about that. We like to think healthcare is different. And we, aim to do no harm and we aim to do what's best for patients, but those lines get blurred very easily. And it's not fair what we've done to providers. It's not really our fault. This is how we make a living. And volume is fee for service. Fee for service is volume. We do more, we do more, we do more. And by doing more, we make a better living. And it's driven providers who really can't handle it anymore into cash pay practices, right? Where they can do what they think is right and offer services and be in a completely different paradigm. It's moving to out of network. It's like things that aren't making sense, again, are all driven, or a vast majority are driven by this volume system set up not by us, right? We're not taking blame for it, but it's set up in a way now that is so entrenched in the way we practice any kind of medical care that it's hard to see the forest through the trees, right? And it has to go. We need to move out of a fee-for-service environment to one where there's accountability, because these are human lives, right? There needs to be accountability for what we do, why we do it, and when we do it. And doing the best for patients requires being paid differently, right? We want the dollars to come to outpatient providers, community providers, whenever possible, because who wants patients to have to be in hospitals if they shouldn't be, or if it's avoidable? That's what gets me up every day and excited about value-based care.
And I just feel like you and I have converged on this same topic, because I'm just going nuts as a continuing education provider to be like, I see the best practices. I see that they work. I see that there's therapists out there fighting the system, but the system and doing great by their patients, but the system overall does not set you up for best practices currently. Like, we have to shift. I remember so distinctly in 2012 or 13, where I read my first book about value-based care, and I was like, it's coming. And honestly, Dana, I feel like I've been sitting, waiting for it, but feeling like it will never get here until I heard you on a podcast, and you gave me this glimpse of it's here. It's just not equally distributed yet.
That's right.
What is here now for us in terms of value-based care? What programs are out there? Are they working? What are you seeing? I don't even remember what podcast you said that on, so hopefully you can take it from there.
Yeah, for sure. Absolutely. So if we just talk kind of basics about value-based care and about what these kind of programs look like. First, let's talk first about the commercial market, because it's the smaller, more simple way of thinking about value. Employer-based plans, self-insured plans are getting into some of these episodic contracts. So what that looks like an employer-based or commercial contract for episodes of care directly with a provider or with a payer-provider agreement, are things like care that's very variable and where best practices are not incentivized through fee-for-service naturally. So a good example, where you'll see some of these commercial episodic contracts, are things like low back pain or laminectomy surgeries, right? So as you can imagine, we all know, laminectomies sometimes are done on the wrong patients. They're done without the right steps being taken before. The failure rate's really high. There's a variability in the types of ways that patients are operated on. And none of those things have any policing by anyone, right? Providers are able to do what they think is best. And while that's usually okay, and we want providers to have autonomy, we also want to create the right structure so that they don't have to think about what's best for their own being able to bill for something versus what's best for patients and make that judgment call. We want to separate those things by saying, we're going to look at historically the best outcomes, the best total episodic spend. So that'll include everything over a time period. So 30 days, 60 days, 90 days. And we're going to make an estimation as to what we consider to be a good spend, right? A spend that is high value, where the outcomes are good, and approximately what went into that. and will establish targets for patients that have or that specific condition. And then the goal of the provider who is ever taking, in that agreement with the payer or with the employer, if it's the employer sponsored plan, who's ever in that agreement then will be compensated for doing the right thing when the outcomes are good, right? So if we want to, maternity bundles, it's another great example, right? Again, outside of really what therapy sees typically, but not always, C-section rates through the roof, right? So how do we incentivize OBGYNs if we can create an incentive for them to do a procedure that potentially will lead to lower reimbursement? Creating an episode is a great way to do that, right? Establishing quality, establishing the incentive to do C-sections only when medically necessary. Episodes are a great way to think about that. And that's typically the younger population. We're going to see many more episodes versus taking on a whole population. So when we move to something like Medicare, which is where chronic diseases by that time have started to build up, right, and are causing oftentimes complications. Patients are often with the same provider by that point for long periods of time, so they have a relationship with a physician. They're using the hospital more than anyone, and their care is not coordinated, right? No one is being paid to coordinate care between providers, to make sure patients are coming in for wellness visits, to, any of the things that don't have billing codes. We don't have a structure if we don't have a structure to pay for it, we have to come up with an alternative solution. So we have the episodic models I spoke about, and then we have they call total cost of care models. So an organization, and there's lots of different options for the organization, an organization will get into an agreement with a payer of any kind. There's lots of ways to do it, where they will say, okay, we're going to look at the risk of your population. They use data. They just go in and look at claims data, and they know the general risk of that practice or that organization's patients. And we're going to crunch the data, and we're going to come up with a benchmark, which is a total estimated spend over up the time period of 1 year. We're going to come up with an estimated spend, and then we're going to tell you what that is. And your job as the providers that are joining into this model, your job is to just spend lower than that spend while maintaining or improving the quality of care. There's a lot of ways we look at quality in the accountable care space. It could be things like managing blood pressure for those with hypertension, being on a beta blocker. It could be those with diabetes with a hemoglobin A1C under 9. And then it can go to outcomes. So things like days at home for chronically ill patients. So taking that practice and paying them either a reward at the end based on how they do, the mechanism of payment being different, paying them prospectively, higher amounts than in the past, for example, and then reconciling. This is like what they call a total cost of care structure, and one of the more popular types. The Medicare Shared Savings Program is in statute. So we talk about the physician fee schedule all the time. Part of the physician fee schedule is the Medicare Shared Savings Program. And it's in statute since 2012, I believe. And it is updated through rulemaking every year. And it's improved upon, and the incentives are improved upon. And it's now grown to about half of all beneficiaries in Medicare are in either the shared savings program or another one of the programs developed by Medicare. And that's a big number. We're up to a large percentage of patients in fee-for-service that are in these models. Let me stop there because I want to make sure I'm covering and see if you have any other questions from what I said so far.
I'm just listening to you talk, and what's jumping to my mind is I'm like, the benefit, I hate to even apply the word benefit, to our fee-for-service model is it was simple. And that's how we got it. Like, you come to therapy, this much, it costs this, and there's complications with insurance, but it's pretty simple. What I hear you talking about is something that we couldn't arrive at this place until now because you need so much data to be like, this is an average that we expect for an episode of care. Like, I'm like, that's a lot of data to start figuring that out.
Yeah.
Like, of course, we just arrived where we're like, finally, I'm also like listening to these AI podcasts and I'm like, oh, yes, I see the data coming where we can really estimate these averages. But I'm hearing that in these new models, we need to like channel our inner Dana, and we need to be like tenacious and collaborative because we're working. It sounds like we're like working with a team, or like we need to get in with these teams, and we need to demonstrate our value in ways that we haven't done before, and they make sense, but it's different and it sounds more complicated to me. So I guess my question is like, how as therapists do we get into these new models? Are we in there already?
Little.
Yeah, what does it look like where we're at a little?
So let me
Paint for me
first.
the simplest version of where it's at now.
Yeah. Well, just to one more point on fee for service. The reason we're in fee for service is not just because the system was set up that way. Fee for service has multiple problems. I would argue the other is the way we've weighted each of the different services. There's thousands and thousands of services that have weights and value units, relative value units, and weights per provider type. The way we value them is through the RUC. And it stands, I don't want to get it wrong, but it's RUC, and it's an acronym, but it stands for the AMA, the American Medical Association organization, driven heavily by medical specialists, physician specialists, who they themselves decide which codes and which procedures and which services get which weight per provider type, right? So again, lots of we generally have an idea of what specialists, especially interventional, what they earn. Not saying they shouldn't earn, really good salaries, but the physicians themselves are determining themselves what everyone should be paid and what should and shouldn't have a code associated with it. So the work of OTs, the work of PTs, the work of primary care, lots of it has no billing codes, right? I heard a statistic a couple of times that if primary care physicians were to do everything that they were supposed to do for their patients, all the care coordination they were supposed to do, all the proactive outreach, it would take 28 hours a day. It's not possible, which is where the team-based care component comes into play and where therapists have this opening. And wait, I covered the fee-for-service thing. Tell me repeat the second question again for me if you can, Sarah.
I was just like, I'm hearing these models and integrating ourselves into them sounds more complicated than just like, you refer me a patient, I get this much.
Yes.
It sounds more collaborative.
It is.
Which I think I like the sounds of, but I don't quite understand how we get there. Like, how are therapists doing this already?
Yeah. So one way to think about what's being done already is to go to our kind of sister provider type. I'm going to call it that because there's a lot that's similar that doesn't feel similar. And that's the behavioral health specialists, right?
As OTs, we're like, totally, those are our sister.
Of course, right.
Yes.
PTs may not say that, but OTs would. Okay.
Yes.
So behavioral health providers, the question is done. The question's been answered. They belong in team-based primary care. Why? Because behavioral health providers have made the argument successfully that by having billing codes that allow this and facilitate and incentivize this, right? By them being a part of primary care and closely connected, we can, and here's the key, so where we fit into, we will avoid downstream avoidable negative spend. And by managing behavioral health conditions, we then facilitate the ability to get those patients' chronic medical conditions managed. And we're offloading work from physicians that shouldn't be on physicians. That's right. So when they're embedded in a practice and a physician sees a patient whose primary complaint is depression and anxiety, and you have the behavioral health provider right next door versus making a referral, hoping they have transportation to get there, figuring out who the insurance is, all of these things, right? And especially if you're a provider whose decided to take on the risk and the benefit of managing spend and doing the right thing to manage spend, it makes complete sense. They're embedded, they're making a big difference. OTs and PTs just have to demonstrate why, if they're in the practice too, or if they're a very close, simple access referral away, how and why they will help providers and typically, like I talk about advanced primary care providers and teams, they're going to be the easiest to sell this to, right? It's not even really a sell. It's being able to speak the language that, the kinds of data that these practices are looking at to decide, okay, I know I have to reduce the spend in these areas and it's best for patients. One of them, let's say, is falls. I have a high hip fracture rate compared to what it should be. And there's ways to normalize some of this data so that I'm above average, I'm below average, right? We have a high rate of hip fractures. We have a population that's older and more frail and less safe. Well, one way to address that is to be able to connect patients proactively and reactively with therapists, right? That's just one simple example. Or a patient has carpal tunnel and they come in, and what is the primary care going to do about carpal tunnel? What do they typically do? They say, well, you probably need therapy. They might give them a painkiller. If they ask for it, they might send them for an x-ray or an MRI or to an orthopedist. But imagine if the OT is in the practice right next door and the physician knows what they can do and just schedules them or walks them right next door and the OT sees them and avoids all of that spend. It's not just about money. Money and quality are aligned here, and that's why it's so magical. We want to get to patients at the right time, and we're not doing it by being only on the outside, right? We can, and we do amazing things, but we are not accessing all the patients by any means that we could be as therapists. So understanding that when a physician practice, again, as an example, has decided to own the dollars and the spend for their patients, they look at what are the opportunities to improve care. And then they decide to spend money up front to make things happen to improve that care. So it could be home visits. This is what's happening right now. Home visits, telephonic care coordination, telehealth visits with RNs instead of with the physician, because they don't have to worry. They're not worried about the transactions. The RN can see the patient for chronic condition follow-up, right? They're making e-consults to specialists while the patients are sitting in the office, having a contract with an electronic consult specialty company so they can avoid a lot of the specialist visits that may not be necessary if they can get a specialist consult doctor to doctor. Or they can, and there's even therapists that are functioning in these e-consult companies. So it's understanding that these practices, it's mostly practices and health systems that are taking risk in these contracts. And they are not thinking transactions anymore, not in the same way. They're thinking, what interventions can I do based on what I see is avoidable, unnecessary, low value spend? What can I do? What money can I spend up front, because I have the money now, to put into caring for patients proactively so that they don't end up in the hospital and start cycling the system, right? I can address social determinants of health. I can work on group therapy. I can offer group exercise classes. I can do whatever I think is going to be best for patients to manage them, and they have a better experience. And in the meantime, we're avoiding spend that will come back to the practice. That's where the money is going, right? Payers want to be in those contracts, and therapy is not part of the conversation. Payers do better when they're in risk contracts with providers, because now the providers have the same incentives as the payer, right? Every payer and provider, we want them both thinking at the same time. We have one bucket of money. The payers have a bucket. The providers have a bucket. People fund the payers. The payers don't magically get the dollars, right? If it's Medicare Advantage, CMS gives them the money, and they have that pot of money to work with. If it's just a commercial plan, it's the employer, whatever it is, the payer is the one managing the dollars, but they have a fixed amount. We want the providers to give, if you're a payer, you want the providers to give the right care at the right time. You want them to identify, what do people need, even before sometimes they know they need it. And that doesn't have to be a transaction that has a CPT code attached to it, right? Does that make a little more sense, kind of foundationally, do you think?
Yeah, and I want to share a little bit, or just like an anecdote, and then try to tie it to an action step to what you're saying. Like, I was really, I got to work at my small town hospital. And there was a funny anecdotal difference between myself and the PTs. The PTs were always like buddies with the specialists that would come in. As the OT, I loved being buddies with our doctors, and really get on the phone and collaborating with, like, we have this patient, we're worried about their driving, we're worried about them at home, and really like send those patients to me. I'll check this out. Let's be in close collaboration. So I'm like, ooh, I think I've gotten a taste of what you're talking about, this like close collaboration with primary care. And I know OTs are so good at it. Is the action step from all of this for like an OT right now, is one of the best things we can do is like figure out our primary care doctors in our area, figure out what payment model they're under, and whether or not they're under one of these payment models, to start strengthening that relationship. Like,
that would be the first action step.
That's the action step. And I'm like, oh, we're so good at that. And PTs are too, but I'm just like, oh, I got a taste of that. This is all about
OTs, totally.
Yeah.
Go to the easiest way, because it's public, is to look at the Medicare Shared Savings Program and the ACO REACH model. So these are two total cost of care programs through Medicare, and all the participants are made public. So you can look at how they've done historically. You can look at how long they've been in the program. All of this is published. By knowing that, then understanding that that's first step, and just start building the relationship with them and start understanding what their pain points are that they're trying to solve for. If they're an early participant and they're not taking a lot of risk, they're just joining for potential shared savings, they'll be a little less motivated until they have to take on more downside risk. If they're in a full risk model, they'll be more motivated, right? So I'll give you an example in the ACO REACH program. So this is a CMMI model. So that's the Innovation Center for CMS. The ACO REACH program is a program where CMS is paying the primary care, but it could be different entities. They're paying the practice bi-monthly. They're paying them higher than they've made in the past in their historical billing, because they want them to invest those dollars in proactive primary care. And they want them to build out teams, right? So that those teams can look any way they want. They want those teams to figure out what is the right thing each of our patients needs to optimize their health, right? There's also these, what they call waivers and flexibilities. So everyone got real familiar in COVID with waivers, right? And what you could do and how you could make things simpler. One of the really interesting waivers in the ACO REACH program, and it was in its predecessor was direct contracting briefly, which we may see come back under this administration, the next generation ACO model. These programs have had a very interesting waiver, the home visit waiver. So for anybody with chronic illness, they allow non-physicians to go into the home, there's special billing codes for it, and do a wide range of things to help them be successful managing their chronic condition. And they also have another waiver allowing home visits, again, wide range of providers, OTs included, to make visits to help transitions of care be successful. A lot of us are familiar with there's care management codes. There's transitional care management codes primary care uses since the Affordable Care Act, chronic care management. These are actually home visits. So, right, when you have a patient come home and we know that they are, because we know in the claim, we know looking at their data, their claims data in the program, we know they've had 5 ER visits, or they've had 2 hospitalizations, whatever it is, we know that when they're discharged from the hospital or wherever they're discharged from, their risk of being rehospitalized is high. And they may or may not have home health. And lots of patients, home health isn't the answer. And a visit separately by something like an OT can make all the difference. By having those eyes on patients in their home, seeing, we all know what OTs can do and what they can provide here. They can help the practice have eyes and ears in the skilled way that only an OT can. So it would just, in the case of the ACO REACH program, it would be making the case to the practice that's taking risk or the organization taking risk that you can help use that waiver that they have available, use that waiver to make home visits, and you will be the provider that's contracted to do that. And you will agree to whatever it is that you mutually agree on, whether it's you have to be there within 24 hours of discharge from the hospital, or it's you're going, to have access to their EMR and document right within it so that when they schedule the follow-up, they can read what you've done. Or maybe it's, you're identifying that they need something that they don't have, and you're connecting with the practice so they know right away. They know before something bad happens. Admission rates and readmission rates are two of the highest levers of spend of any total cost of care program that CMS, the Medicare population, has. And OTs are experts in keeping patients home. And that should be a theme that OTs watch really closely, if you aren't already, is care in the home has a lot of benefits that now we have the technology to support it. We can actually make use of, right? So now that we can have patients home and have the technology to monitor them and build programs and support around that, OTs, they thrive in home environments and the real world. And that's going to live partly outside home health more than it probably has in the past, because a lot of that spend is potentially avoidable, right? If a patient just needs OT, maybe they need OT and PT, maybe they need OT and a nurse visit, but they don't need the full home health episode. You can imagine that providers are looking to give the right services, not more than necessary, the right services. So being a provider like an OT who's working in a practice, and part of what they do is make home visits and bill Medicare Part B, this is a whole new avenue, right? The guide model, I'm sure this is something that your listeners are following closely. The guide model is another huge opportunity for OTs. And it's not like a unique opportunity where it's only that model that's the opportunity. It's use this as a way to demonstrate clearly, publish about it, how you're impacting total cost of care, the patient's journey along the care continuum as a whole, right? What is your role and how are you contributing based upon your participation and support of these models? Because part of what, right, we're building this momentum, and we're trying to create like a flywheel, right? Where therapy is demonstrating their value through the opportunities we have in different payment models, so that it's just becomes the norm, and use the behavioral health provider success as kind of the guiding light. They had to go through a time period of, meeting with CMS, proving their participation in different models, right? Publishing about this. These things, these different actions all together are what eventually build the profession to a place where it's just the norm. And I don't imagine any world where, can't tell you how many years, but I don't imagine a world where therapists are not just part of the primary care mindset. Another reason is workforce, Sarah. So sort of off the topic, but very much on also, we don't have anywhere near enough physicians. Advanced practice providers can only do so much, and behavioral health. So if we want to build successful advanced primary care teams, we need another source of professionals who are the right people to see patients in that setting. And that's where the therapy professions come in again. Knowing that what the solutions could be, because you understand the model mechanics, it's all publicly available, right? And certainly there's a number of ways to learn it. Maybe we'll create something to teach therapists more about it. Once you know it, therapists are so friggin' smart. They will come up with the innovative solutions. You just have to know how the models work. And you'll be teaching me things that I don't know that you can do.
I get so excited because I hear the kind of work you're describing, and I'm like, yes, this is what we love. We love collaborating. We love being in the home. I love that you talked about that. And we love like the flexibility where we're not tied to like, it has to be about ADLs. We love the flexibility to come in and problem solve at what the actual risk is. Like maybe it's when they're walking their dog. Like we don't want to figure out how to fit that in a code. We just want to do that because that's like where their risk is. And we want to help problem solve how to make it safer.
Or randomly because they're no longer homebound, right? Now they no longer have access. Well, that's a problem because how else, right? Then you talk about incentives. Again, it's like, well, so just because they can walk a couple hundred feet doesn't mean that the best, most accurate care for them isn't right here continuing where we are right now. But we don't have the payment mechanism to fund it necessarily, or right, the home health agency is divorced from the OT and PT outpatient provider. So another example, right, where get close to home health providers and understand the systems that they're in and what is being asked of them. If you can discharge a patient, right, directly to outpatient therapy, or from home health, they can go right to in the home outpatient OT because they still need it. There's value in that wasn't there before that others care about. We can't just care about it, right? We want to, it's easy to stay in our bubbles, but we have to think about the system as a whole cares about getting more value out of the dollars we spend. And that's where OT specialize. They are exceptional at making things better for patients to prevent the things that nobody wants to happen to themselves or their loved ones.
Concretely, if I'm thinking about making the case for OT, I guess I'm like going back to like, I contact my local primary care providers, start conversations. When I'm making the case to be thinking about OT on this team, like at this micro level, is it like the research that supports us? I think I feel a little like overwhelmed because I'm like, I'm not tracking currently like how many readmissions am I reducing? I don't know the metrics to justify, like I know we're doing the work. I don't feel confident that I have the right metrics to justify it. Or is it a matter of metrics, or is it just telling the right story and understanding the right words? What do you think therapists need to be, what do we need to be successful in getting ourselves embedded on these teams? Are we the biggest barrier, believing we don't have the right metrics, but we actually do? Like, what do we need? What information do we need? We're overachievers as OTs. We want to have all the information to make the case.
Totally. It's first realizing that not everyone is going to want to talk to you. It's who has the incentive to talk to you and why. So starting off, right, there's a stepwise approach for sure, but I would break it down first into just knowing what groups around you are in these models, right? Start there. It's easiest to convince a group that's taking significant downside risk. And what downside risk means, to really simplify this concept, because it's an important one to get, is when you take downside risk, you also have the opportunity to earn more, but you could lose also. So what that means is, let's say they give you a target of $1 million, right, for 1,000 patients over the year. But your patient's utilization of the health system is $1.5 million, right? You are going to, if you're at full risk for those patients, you have to pay back the payer for the dollars that were spent above what they anticipated. So when providers go at full risk or significant downside risk, it could be a percentage. So there's some of the models are something like a 15% or a 40% cap. So if you overspend by $1 million, you'll have to owe back a percentage of that that's established in your contract. Once providers realize I could lose, and I could lose big if I don't do this right, they are incentivized to open their ears first, right? The earlier, easy, upside only models, it's very hard to make the case well. Not saying it can't be done. It's just harder. So you're, seeing who's in these models and then having a general idea of before you go talk to someone. And you certainly start with one provider who you already have a relationship with if you're an outpatient OT, let's say, understanding what their data looks like. So you can, OTs, PTs, anyone can actually buy access to the data for any set of providers through Medicare, through companies that have access, right? So there are certain kind of data companies that have access to all Medicare data. And what that looks like is it'll tell you all of the ways and what days of the year every person in that practice spent dollars in healthcare. And when you look at that, you get an idea of who is using a lot of care. And most of the time, practices are blind to it before they get this data. Oh my gosh, Mrs. Smith went to the ER 12 times last year. I didn't know that, right? So you see their diagnoses, all the diagnoses that they've had, acute and chronic. You're going to see where they've been in the health system. And right there, what jumps out at the providers that are in these models is, okay, here's our opportunities. We think we can avoid this, we can avoid that, we can make this better. And then they develop programs to make that successful using the team-based approach. So for OTs, you would think about what types of patients, what types of scenarios, what types of conditions, if you can imagine in your head, right? Patients who you say, oh, if I had only gotten to them sooner, right? Oh, if I had only been able to be given this patient or I had seen them proactively, we could have stopped this. That scenario is where you're going to take that kind of scenario and imagine what that patient would look like. And then think about the kind of claims that patient would have, right? So maybe it's ER visits, maybe it's orthopedic visits, maybe it's imaging for certain conditions, maybe it's, falls, home safety, anything where you're seeing issues in the claims to say, oh, that could have been avoidable, right? A lot of it, I would assume for OTs will fall into that kind of home safety. You tell me. I would love to know more about this as I kind of ideate around where the best value would be, where you would have the easiest time having a conversation. But it all is based on the amount of risk and what is in the data, and not the data we're thinking about. Data is claims data, diagnostic data. And in CMS, it's very transparent. You can buy access to that data, and it's laid out for you. It's a lot harder when it comes to plans. Now, there are some data companies that have the plans data too. That's a big step, and it's not free to access that kind of data. So just understanding what the data looks like and what big ticket items that provider could be trying to solve for and probably hasn't yet. That's where I would begin. You begin with how you can provide quick access to the practice when they identify X, Y, Z, A, B, C in their patients. How can you be the first person that they access? And how can you get to them within 24 hours, let's say, whether it's the home or the clinic or whatever? How can you make that process simple for them? And start every single patient in the beginning. You're tracking the outcome of what you do. Maybe it's following up 30 days after you discharge them and capturing that. You're going to build the case that what you do will help that organization be successful in avoiding bad spend, right? Negative patient outcomes. And then you start to have the tools and the leverage outside of going to a data vendor. You'll have the tools and the leverage and the approximate return on investment, which you can estimate, knowing what the cost of an admission is, let's say, or the cost of an orthopedic visit. And you can start to make that case. It doesn't have to be exact, right? If you're at a practice at full risk, they want solutions that are not medical specialists. They want solutions that are not, emergency patients showing up on an emergency at 7 o'clock in the evening to the practice and they can't address it anyway. They want solutions that they simply and they can trust that you will provide to them, right? That'll address things that they want to get control of because it's going to help them be successful. Does that? I know it's not totally concrete, but aside from...
It's very concrete because I heard the argument that we need to make for ourselves is in terms of money. Mm-hmm. Like, we don't...
It's money.
We just need talk in terms of money. And we don't need the...
Thank you for simplifying.
We have enough research. We know our expertise. And it also sounded to me, too, that we almost want to present ourselves as we're your Swiss as OTs, and we're your Swiss Army knife where you can deploy us in so many of these 90% of your cases, and we can help you reduce your spend. And we'll help you identify who needs to get to the specialist fast. But think of us as your Swiss Army knife where we can dig in. And this is what OTs are so great at. We can help get to the root of the problem and identify when there will be times when you need the specialist. We can help you with that too.
That's exactly right.
We can help.
Here's another great example, just to get kind of picture something else where you could offer support. When patients discharge from, let's say, skilled nursing facilities, right, their readmission risk is high. But a lot of times, the only thing the skilled nursing facility knows to do and has relationships with home health agencies, and so it's just the habit of the discharge planner, is they send in home health. They just refer them right to home. They could be walking independently and they're sending home health. So by providing a solution such as, we'll just go to the home and do an OT Part B visit, and let's say I make 4 visits total. I'm just throwing a number out there, and it costs whatever, $700-800. You're going to avoid this entire home health spend. And a lot of times they need 1 or 2 visits, right? You're helping more independent patients, just making sure the home environment's safe. You're training, you're following up. Think of it this way. There are organizations right now selling this solution to ACOs, but they're physicians or APPs. And they're saying, just send us in for the transitional care visit, make the referral, and then we'll look for anything else. Except the problem with that solution, and there's patients for whom that's a good idea, but the problem with that solution is it's not necessarily the right solution, right? Your APP is not going to be an expert in where grab bars should go or whether or not the patients, how they're doing. I'm not an OT, so I'm just kind of throwing things out there. But you know what I'm saying. They're not the right provider to solve for those problems. And maybe it's in conjunction. But we have to start questioning things like, just because it was done in the past doesn't mean it needs to be done in the future. And doesn't mean that anyone is benefiting from it other than those who are presently billing. So if I'm the home health agency, I'm not going to like the solution to avoid home health. I may know it's right. In total joint replacements, we had this came up in the total joint replacement model where, we were discharging patients to home health, but some of them didn't even need the nurse. They really were not homebound beyond a day or two. So for a certain percentage of patients, we were skipping home health and going right to outpatient therapy in the home. It saved another couple of $1,000s in a lot of cases. So it is a fortune. You have to say, maybe unfortunately isn't the right word. Fortunately isn't either. It's just factual. Money is what's been driving fee for service, and money is what's going to drive success in value-based care. And if you understand the way the money flows and where the incentives are, very, very smart people in the therapy world can figure out how to be the solution for the problems that are unnecessary, poor quality, avoidable spend for all kinds of patients along the continuum.
And the money in the past, how the money has flowed, has been such a disadvantage to us as therapists. One, because we're at these lower rates, and two, then as OTs, because we're like, we don't like this volume model. We want to get in there deep and problem solve and be done.
That's right.
And that's what's going to set us up in this new reality so well. And if we don't claim it, someone else will. I agree with you. I see those startups are like trying to move into this space where I know OTs would be really good. We're getting close to the end of the time, but I have two more questions I want to ask for sure.
Yeah.
One, I'm like, yes, I'm so excited. We have all the clinical skills. We have the community. We're collaborators, but it still feels like we have a lot to learn about the models. How do we do that? I want to say two concrete things. One, I'd love to like create a glossary with you of terms. Like one of it, I think is just like getting used to the language of it. And I would also love to do like a live episode with you where we like look at one of these spreadsheets of a provider and be like, oh, this is what it will look like when you're looking for how you can save money. I think that would be a really fun episode. What beyond those two ideas do we need to do to keep up and learn?
Yeah, and we'd be remiss to not say that these models are a big paradigm shift and come with, learning a different language. And it's not a language that, takes more than learning it. Like you become fluent pretty quickly if you devote the time. Certainly I haven't found any good courses and especially directed to providers and to providers that haven't been integrated into these models yet. So maybe it is like developing some kind of a course for OTs, PTs,
and no one else is
other providers.
Incentivized to teach it to us but ourselves.
No, exactly. Exactly. And I know it, I sometimes when I talk about this, I think therapists think, oh my, it's too much. I don't know where to begin. The only place to begin before anything else is just to understand how the models function and understand how providers that are successful, how they're being successful. And once you see that, right, it'll jump out at therapists to say, oh, well, what we should be doing that. Well, why aren't we plugged in there? It'll become more obvious. It's just learning how the models function, especially the big models like the Medicare Shared Savings Program, which is in statute, it's permanent, it's iterated on every year. Every therapist should be fluent in the Medicare Shared Savings Program. And I don't know many that know it well, or even know like anybody that's participating in them. And right there, once
literally
you
did not know that program until you said it.
No, of course not. Because why would you?
I'm like, yeah.
Medicare Shared Savings Program. And it has a number of different risk tracks as you get into more risk, it offers more waivers. It's a way to get even health systems can participate, but it's a way to get providers into this glide path where you get them into the model and they start taking more and more risk. And then over time, as they take full downside risk, they transform how they provide care. And I'll say one other thing. Don't think that it's out of the realm of possibility that this new administration could mandate participation. So imagine if they said, so the team model is a mandatory model. Now it's time limited, and I jumped to team, so forgive me, but there's a mandatory acute surgical episode of care model that's coming up. It builds on other models. It's mandated in over 700 hospitals, and there's no way to get out of it, right? And the idea is if it works, they're going to build and add additional diagnostic groups to it, and then it'll just become part of the inpatient payment system, which is how hospitals are paid by CMS. No therapists want to be in the position where we don't know how that model works and don't know where we could fit in, because that's where dollars are being directed, right? If they could mandate whatever they want, really, if they mandate participation by primary care, let's say, right? I have no inside information that that's what's going to happen, but it could happen. And we don't know about it. It's going to be a race to catch up and figure it out. But the Medicare Shared Savings Program is becoming the norm. Half of your patients are probably in one and they just don't even know it. It depends. Parts of the country are really heavily weighted. Some have more MA, A lot of Medicare Advantage has a very similar program, or full risk program, same idea. But the reason it's getting bigger is because it works, right? It's like MSSP saved almost $2 billion last year, or 2.5 billion, 1.8 the year before. Billions is a real number, right? This isn't a couple hundred million. This is real money, and it's got tons of growth ahead of it. Where is that money going? That's the first lesson. Lesson number one, we save money in the Medicare Shared Savings Program participation. Who gets that money? Well, the provider gets some portion of it if they do well in the program, and then CMS, or the payer, gets the rest. If you take full risk, you can earn up to 100% of those dollars. So those dollars that could be being used in other places, like paying for outpatient therapy or paying for any host of things, inpatient, outpatient, they're being directed to the providers that are in the models. And this is a closed system, right? There's budgets that create how much money is available in these programs. We don't have control of those budgets. The federal government does, right? Policymakers decide on the budget. And then CMS, the regulators, they decide how to move those dollars in the right places, depending on changing market conditions, depending on, what they think makes more sense for the population that year. The money it doesn't go on forever. It's a closed system, and we're running out of it. So if you have to follow the money in healthcare. We're therapists we think so much about wanting to do good. We have to think more about, don't lose the do good, but we also have to think about, where is the money living? Who has it? And is it in the best places for patients? Because where it's best for patients, this is the big secret, where the money is best spent for patients is also going to be what's best for the providers taking risk. And it will, as this builds, it will not be as great for providers that are not part of where those dollars are going, and certainly inpatient settings, right? So if I'm an inpatient post-acute provider, I'd be concerned about how am I evolving, because there are a lot of options developing that we can, where patients can go and are avoiding altogether. But any outpatient providers, you can get in the game now. You can't get in the game unless you understand the structure of the model. And trust me, it's not that hard. It's just learning it. And we can make it, you and I, we can figure out how to make it simple so that therapists go, oh my gosh, I get it. Wow. There's all of these opportunities.
Oh, there is just I hear multiple things. I hear a flip in the reality where we've been, where I'm historically I've been oh, the specialists with these high dollar surgeries, they are the pinnacle of healthcare. And there's going to be this complete flip where I'm primary care, therapy, these high value, relatively low cost. We have a new central place in this healthcare reality. I also hear that value-based care has been this flame that's been burning like just a beautiful little flame. There's programs going, but we have accelerants being poured on it of a changing administration that's going to want to create change. We have these AI-driven tech platforms are we want to be a part of the data solution behind all of this. And that that technology part is another accelerant. And people are fed up with and that's public opinion is no, we're fed up. I think that's another accelerant.
100%.
Close us with your big hope and your big fear for this.
I would say I'm hopeful about value-based care. As a whole, I think it's an inevitable. There's no going back. And it has bipartisan support. When we have two parties in support of value, Democrats are going to favor things that are more whole person and health equity driven generally, and Republicans are going to favor taking on more risk more quickly. But that's just different flavors of vanilla ice cream. They both are going to create financial incentives, as they already have been, to join these models, I'm very optimistic about that. What I'm worried about for therapy professionals is that they're sitting this out because of some of the most basic reasons. They're very busy trying to survive in their own jobs. And so it's really hard to listen to everything else going on. And they're not aware of where they're part of the solution. We're not advocating to CMS to involve us in different ways in primary care codes, right? Like behavioral health did. I don't think either PTs or OTs are meeting with CMS to argue for heavier weights for their codes or creating care coordination codes for therapy and primary care. I don't know of therapists that are really involved in any meaningful way other than some episodes of care that are being developed by physician practices mainly, that are working with therapy groups to enable it. Well, we can do that ourselves. So my worry is not value-based care is going away. I'm very confident it's here to stay and it will continue to accelerate. I'm worried about the therapy professions not taking this seriously and not finding time and energy to learn the basics of how to participate, what success looks like, so that then they can begin to either dismiss it if you choose, or imagine this new paradigm and it's like a new awakening when you realize the value you can bring to patients and these new programs. And so I guess that, yeah, I know it's simple, but that's my fear.
It's that little fire of value-based care that's going to grow and burn through everything, and we might get left behind is the fear.
Yeah, I'm worried about getting left behind.
The hope for OTs is like, it truly feels to me, Dana, like we were made for this moment. Like we are incentivized to change because it has not worked for us. We are collaborators. We love to like be on that team that's getting really deep and figuring out the best solution for our patients. Like we are so good at that. And we can talk in terms of money. I know that's not like our first language, but OTs can do that.
Definitely. Of course they can. They have to be given permission to maybe. Please do.
Yeah, please. Dana says it's okay.
But what is special, especially for OT, every time you talk, it makes me think of something else that I think is valuable. This may be one of the more valuable things. As providers get into these deep risk, because remember, they've been on a trajectory generally where they're in upside, then a little downside, and more going to full risk. That means to be successful, they really have to support care in the home. And complex patients, any kind of patient that they're responsible for, if we're trying to avoid these high cost, like black holes that a lot of inpatient sites of care become for primary care practices specifically, we have to find the right solutions to keep patients home. And really, no one is better than OTs are. We have to be that solution for them proactively so that they don't have to, they're not going to come to us, put it that way. Physicians are not thinking, oh, I think occupational therapists will help me to avoid these admissions or readmissions. They're not going to think of that. We have to know the value, that the monetary value, right, to providing that upfront so that our services can yield success for patients, success for the system. These things only work when there's a win-win-win. Value-based care is so beautiful because it's a win for patients. They're getting the right care at the right time, evidence-based. It's a win for providers, especially in primary care, advanced primary care, therapists. Really big win for them because they can finally be paid for all the work that doesn't have reimbursement codes, and they can see patients at the right time and have a bigger impact, right? And it's a win for the payers because when providers are incentivized to care for patients in a way that's best for them at the right time by the right provider, they're spending less of the pot and they have more of the pot to go around without having to grow that pot through higher premiums, through the Medicare trust fund that's disappearing. It's a win-win-win. There's not a lot of places in medicine where you have a win-win-win. Value-based care is the only one. I want everybody to get excited about it. It's amazing that this is available.
You have done such an amazing job of painting this as a win-win-win for our healthcare system, but also painting this as a win-win-win for us as OTs, where we get to collaborate, we get to do that deep dive of problem solving. We love being in the home. Can there be more opportunities for that? And I think it's going to leverage our strengths. I'm so excited, Dana, about this conversation, but also to keep learning with you. And I just want to say, I'm like, you could be having all kinds of conversations with anyone, and that you took the time to have this conversation with OTs. I'm so thankful for that, and just thankful for this time together. I hope we get to keep learning together.
Absolutely. I'm so thrilled that you were willing to talk to a PT in value-based care, and you saw the benefit to bringing these concepts to the OT profession. And it's not to say that of course, there's some PTs and OTs that know the model. So I don't want a blanket statement, but there's so much opportunity to expose more folks to this, that it'll resonate with and excite them it excites me for our professions. And just one last thing to be clear, therapy is not part of my day job. This is my mission. This is combining my expertise in value-based care and policy with my passion and belief that OTs and PTs have never been used the way we were educated and trained and licensed to be used, because of the system that was set up and the incentives that never aligned with us having an equal seat at the table. And now it's possible, but we've been on the outside, so we have to bring what we do to the people that are incentivized to care at a time when they can now care, because fee-for-service is decreasing in its importance. I get excited just talking about it.
Mm-hmm. Oh, like you said, this is a mission. We are excited. I guess I'm speaking for the whole OT profession collectively to join on this mission. And I just thank you for this time, and for being willing to share about this, and just inviting all of rehab into this. I do think together this is an exciting time for rehab professionals. So thank you so much for the time today. This was an awesome way to kick off 2025.
Oh, you're so welcome. Thanks for having me, Sarah.
Wow, you all, I know this episode is so much to wrap your mind around. It is literally like learning to speak a new language. But the most important thing to me is that you leave this episode motivated to understand what value-based care will look like in your setting. I feel so motivated for us to really take on this learning, because I just know this new reality is going to open doors to practice OT in the way we've always wanted to, where we truly have the time and tools to collaborate with our patients, the entire healthcare team, and even our communities to change lives for the better. We are currently working to understand how OT Potential can equip you for this new journey, so I hope you consider joining us as a member of the OT Potential Club. The OT Potential Club is also where you will go to earn a CEU certificate for your time today. What you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. Okay, I just want to thank you so much for joining us today. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.